Good morning, everyone. Today I am presenting a case of sacrococcygeal teratoma. The patient came to us during the 21st week of pregnancy to undergo second trimester screening ultrasounds at our clinic. And immediately, a large mass with extrapelvic development involving the sacral region of the fetus became evident. The mass appears to have a highly heterogeneous structure, rich in hyperechoic areas, as if due to the presence of calcifications and cystic regions. Therefore, a diagnosis of sacrococcygeal teratoma is made. This is a neonatal tumor, in fact the most common one, with an incidence of 1 in 35,000 live births. It originates from the germ cells of the primitive node, which migrate during the first weeks of gestation to the sacral region of the fetus. Here, in fact, this neoplasm is located, and depending on its development, it is classified into different types. We identify a type 1, which is completely extrapelvic and covered by skin, a type 2, which is predominantly extracorporeal but has a presacral component, and type 3, which is mainly presacral, and a type 4, which instead has complete intrapelvic development without any external component. The most common types, in fact, are type 1 and type 2, which account for 80% of cases. The differential diagnosis should be made mainly with lumbosacral myelomeningocele. However, this presents other signs typical of the ultrasound features associated with spina bifida, such as alterations of the posterior cranial fossa, and therefore defects of the fetal spine. Furthermore, it should also be considered. The differential diagnosis should also be made with other masses, such as rhabdomyosarcomas, angiomas, and those that in fact are listed on the slide. The diagnosis is straightforward due to the intrinsic characteristics of the mass, which, given its histological nature, contains all the tissues belonging to the three embryonic layers. Therefore, it presents an extremely heterogeneous ecostructure, as we can see in the ultrasound images. We went on to study the vascularization of the lesion, since its pathological significance is mostly related to its vascularization, because due to the presence of vascular shunts, it behaves like an extralobar sequestration and can therefore cause anemia and fetal heart failure. In the specific case of the lesion under examination using the transvaginal approach, we found the presence of arterial vessels and significant vascularization. Depending on the degree of vascularization, the ultrasound signs that may be associated for the reasons mentioned above include polyhydramnios, which is the most frequent and occurs in 70% of cases, ascites, and hyperplacentosis, which, as we will see in the case under examination, are present, up to cardiac failure, fetal hydrops, and oligohydramnios. Structural anomalies, on the other hand, are associated in 5 to 25% of cases and are mostly represented by alterations of the central nervous system, followed by abnormalities of the face and the urinary tract, gastrointestinal, and finally, cardiovascular anomalies. Depending on the degree of differentiation of the germ cells involved, we distinguish between a mature variant, an immature variant, and a malignant one, which has the worst prognosis, often even after surgical removal. We then proceeded to study the remaining fetal anatomy, particularly the pelvic and abdominal organs, which appeared normal. In fact, we can see in sequence the bladder, the liver, the stomach, and the kidneys. However, what stood out was the presence of ascites at the abdominal level, which cannot be explained by anything other than the teratoma itself. This is because there are no indications of a possible infectious origin, nor of any cardiac decompensation, which has in fact been ruled out. We can, in fact, observe a regular anatomical study of the heart, with no signs of hydrothorax or possible cardiomegaly. Fetal anemia was also ruled out, as the peak systolic velocity in the middle cerebral artery was found to be normal. The only other ultrasound signs that were found to be associated with the sacrococcygeal teratoma were hyperplacentosis. We can observe how the placental thickness has increased, while the amount of amniotic fluid was normal. Then, upon examining the lower limbs, a slight torsion of the left foot was observed, which, however, does not have significant pathological meaning. Furthermore, through a more in-depth transvaginal examination, we confirmed that it was indeed a sacrococcygeal teratoma of the extrapelvic type, since the lumbosacral segment of the spine appeared completely normal. In fact, there were no associated spinal defects. We observe the sacral segment of the spine in these scans, and subsequently also in the coronal scan. We can see that the spine is indeed normal all the way to the most distal segment, so to speak. The maximum dimensions of the teratoma found were approximately 8 centimeters by 6 centimeters. Therefore, the patient was recommended to have an ultrasound follow-up every 3 to 4 weeks, since management fundamentally depends on the growth of the mass and the possible appearance of ultrasound signs associated with an unfavorable prognosis, such as hydrops or anemia. Possible tocolytic therapy was recommended in the event of signs of threatened preterm labor, since both the mass effect of the neoplasm and any associated polyhydramnios obviously increase the risk for the patient. Finally, she was also advised to have a pediatric surgical consultation for the postpartum management of the tumor. The mode of delivery fundamentally depends on the size of the neoplasm. Lesions larger than 5 centimeters are usually candidates for elective caesarean section due to their large size and the associated risk. Therefore, there may be dystocia during a possible spontaneous delivery. Thank you all for your attention.